Good morning. Welcome to the Argentinian HIV Clinical Forum 2020, Optimizing Treatment. This is a pre-symposium meeting that is taking place before the Huésped Foundation Symposium that will run throughout the week. Today, together with Virology Education, an educational organization based in Europe, we are carrying out this pre-Congress meeting, which is very important for us because of the agenda it has. As the scientific director of Huésped Foundation, I would like to welcome you, and I'm going to tell you how this meeting is going to be carried out. As you know, because of this pandemic, this will be a virtual meeting, so we will be participating remotely through our devices. The organizing committee has 3 chairs: Dr. Jonathan Shapiro from the National Hemophilia Center from the Sheba Medical Center, Ramat Gan, Israel, Dr. Mauro Schechter from the Federal University of Rio de Janeiro, Brazil, and myself. The 3 of us have put together the agenda, which I will soon share with you. Please take note of our schedule. As this will be a virtual meeting, we are going to have 3 sessions. The first one is starting right now and will run until 10 a.m. The second session will run from 2 to 3:30 p.m. I'm always talking about Argentina, Buenos Aires time. And a third session that will run from 6 to 7:30 p.m. This is always Argentina time. This is our schedule for the Argentinian HIV Clinical Forum 2020. Tomorrow we will start with the Huésped Foundation Symposium. We have some objectives for this meeting. We want to learn more about the use of integrase inhibitors in clinical practice. We want to understand the clinical considerations when selecting novel treatment strategies and their consequences. We want to know more about the clinical data supporting the use of long-acting injectable agents for prevention, and we want to have an understanding of the prevention strategies in Latin America. But the global goal is to improve our clinical care of people living with HIV. We have been able to gather a very important group of professors, which you can see on the screen. We have speakers from Israel, Brazil, Spain, US, France, UK, South Africa. So we have a very international panel. We also have speakers from Argentina, of course. So we will be able to exchange very important current information. This symposium is supported by an independent educational grant from VIV Healthcare. They have not been involved in the selection of the speakers nor in the drawing up of the agenda. So we would like to thank them very much because thanks to their support, we have been able to organize this meeting. The first session deals with the clinical utility of integrase inhibitors, and there will be 3 speakers: Dr. José Arribas, Dr. Alexandra, Compagnucci, and Dr. Shapiro. And without further ado, I would like to introduce the first speaker, Dr. José Arribas. He will talk about the present and future of integrase inhibitors. His CV is very long, so I am not going to read it. So I'm just going to tell you that he works at the La Paz Hospital in Madrid. He's the head of infectious diseases and an associate professor at Madrid University. He's the author of several papers, and I have worked with him as co-investigator in several projects in which we have been driving this idea of new treatment strategies. So, without further ado, I would like to give the floor to Dr. José Arribas, who will talk about the present and future of integrase inhibitors.
Hello, good morning, everyone. In the first place, my thanks for the invitation to participate in this forum on Argentinian HIV Clinical Forum 2020 to talk about the present and future of integrase inhibitors. These are my conflicts of interest, and let me get started with a bit of history, although this is present and future. But I want to talk about the long road until IIs were finally accepted. This is a paper, March 1993, talking about the possibility of using integrase inhibitors to treat HIV, but it took 13 more years, 2007 now, when the first II was approved, Cabotegravir, a non-powered inhibitor. After the arrival of second-generation IIs, Bictegravir and Dolutegravir, the slide shows this, but every single comparison of one of these combinations with triple combinations that well-established ones, protease inhibitors, for example, IIs have either demonstrated non-inferiority or even superiority vis-a-vis the others. So I don't exaggerate, I believe, when I state that these drugs have revolutionized the way we treat HIV. And this has been shown by the guidelines. These are the European guidelines for AIDS, and the picture is quite clear. Clearly shows the ART preferred agents, how some like efavirenz and non-nucleosides were there until 2015, but actually now it's only rilpivirine. And as of 2012, the family of drugs that have become more present are the IIs. In the nucleosides, well, that field has been more stable, and we still recommend tenofovir in one of its two forms with FTC or 3TC, and the combination of abacavir and 3TC. But the clear message here is that integrase inhibitors have displaced other families in the preference of treatment. The current inhibitors, all the guidelines for ART recommend the use of regimens with IIs. These are the European guidelines updated in November of last year, the American ones in December of last year, and then the International AIDS Society, they date back to July 2018, and then the WHO. All of these recommend the preferred use of II, Dolutegravir, Bictegravir, Raltegravir, and for the first time I want to underscore that the recommendation is the use of Dolutegravir and 3TC, and also the WHO, that has a more public health approach, only has one recommendation, which is TDF plus 3TC or FTC plus DTG. There's consensus in the different guidelines that these are the drugs of first choice, at least for now. Some comparisons between the recommendations. Bictegravir is a single pill with FTC and TAF, has very few interactions, and it has a high barrier to resistance. Potential disadvantages, doesn't have much data because it's been here for a shorter period of time. It's only available as a single pill, and it has limited safety data for pregnancy. Dolutegravir, we have it again as a single pill combined in two options with one nucleoside, 3TC or abacavir plus 3TC, also as a single agent combined with NRTIs. Few drug-drug interactions. It shares with Bicte the high barrier to resistance, and it's a preferred option in pregnancies after conception. Disadvantages: if used with abacavir, we need to test for HLA 5701. It increases metformin levels, but this is manageable, as we will see later. There are some problems with women who want to become pregnant or around conception. And Cabotegravir, we have the longest experience here. It's a drug which has no interactions, a preferred option for pregnant women. Disadvantages, it's multiple pills, not just one. And the major disadvantage, lower barrier to resistance than the other two. And it's good during pregnancy, but it has limited data around conception. IIs, second generation ones with high genetic barrier, is that we now have regimens for naive and switch with only 2 drugs. In naive, DTG and 3TC. In switch, if patients are virologically suppressed, DTG and 3TC or ribavirin. This cannot be used if you cannot test for chronic hepatitis B because it doesn't include tenofovir, which covers hepatitis B, and in some countries that is a problem. So the message is that if you cannot test for surface antigen, these regimens should not be used. DTG and 3TC has a broad recommendation in guidelines in Europe as well as in the US for most HIV people with HIV. And in combination with 3TC, there's lots of known aspects: the speed of response, durability up to week 96, virological suppression when we analyze below 40. Even for TND, it's the same as triple therapy. We don't have increased resistance data. And compared with TDF, we have better bone and renal markers. We have problems, however, in advanced patients, not much info there, with less than 200 CD4s. Patients had better results with this combination than triple therapy, but soon we will have test and treat data for this combination. For switch patients, we have durability up to 48 weeks, good virological suppression even with TND, no increased resistance, and compare Tango and TAF studies. If we look at bone renal markers and other inflammatory markers, results are inconclusive. We don't know what the impact of archived resistance is, and durability between beyond week 48 is a problem. Problems with pregnancy in patients with tuberculosis and the long-term impact on weight are in red. With ribavirin, the guidelines recommend its use both in Europe and in the US in patients without resistance to these drugs and virologically suppressed. We also know it's efficacious beyond 3 years. From the short studies, patients are equally suppressed as with 3DR, and there's an increased, a slightly increased resistance, only 0.6% in the short study, and it compared with TDF, it's an improvement over biomarkers and no consistent changes in inflammatory biomarkers. The same as we said before, we don't know about the impact of archived resistance or how to use it during pregnancy, plus the weight gain impact are unknowns. For HIV, we have a poor tradition of not identifying AEs of AR drugs until much later. For example, here we see it took us 5 years to know that slavudine produced lipoatrophy or psychiatric problems with other drugs. This slide shows how this delayed identification in naive patients compared using Bictegravir, Entrisitibin, and Teno-alpha versus Abaca and This study has a record. After 3 years follow-up, 314 patients, none of them in the Cabotegravir arm had to leave the trial because of adverse effects. However, once the trials were concluded in the last 2 years, we have come to realize that second-generation II users gain weight. This is a very popular image in the last year. It's a summary of 8 randomized trials analyzing weight gain in patients. Clearly, patients receiving IIs gain more weight than those on PIs, non-nucleoside PIs, and if we look at all of the IIs, Bicte and dolutegravir, worse than the other two. Now, the weight gain with IIs is amplified when accompanied by TAF or abacavir, TDF, or sinovudine. Recently, in the ACE 2020, the virtual ACE, we saw the results of 144 weeks of the advance carried in Africa with these combinations. And it's of concern that at least in this African population, in particular women, they keep gaining weight, in particular if it's TAF plus FTC, more than 12 kilos after a 3-year follow-up. And if we just not look at the weight gain, but also the obesity, it's 12% or 14% for TAF, FTC, DOLU, 8% TDF, FTC, and TTG, and including efavirenz, 2%. So, quite large. We have not seen it outside Africa, but this should be further investigated. So if we have added weight gain as an effect of Bicte and Dolu, but we're still trying to understand long-term metabolic consequences of this weight gain and what is the effect of the accompanied nucleoside. We know that the fumarate has one effect, and teno-ala has also a tendency to increase weight. Another problem with II, dolutegravir in particular, is the use in women who want to get pregnant. And here, this cohort of Botswana, the SEPAMO cohort, was alarming as to the neural tube defects in women exposed to DTG around conception. Fortunately, this signal has decreased in the course of time as the SEPAMO started analyzing data. The initial analysis showed 0.94% versus 0.12% with and without DOLU. The prevalence is 0.82%, and in the slide you see that then 1 year afterwards and another year afterwards the values got closer. The last estimate is 0.09%, those with DOLU during conception versus 0.11%. It's statistically significant, although it's low. So we need to warn women who want to get pregnant if they are taking dolutegravir. Another important aspect is that problem around conception, which in a recent study has shown that after 3 or 4 weeks of pregnancy, it becomes highly safe, the use of DTG. This was presented in CROI this year. The Impact 2010 is the name, comparing women who had been pregnant for 2 weeks and how tough FTC and dolutegravir, TDF and dolutegravir showed no difference during their pregnancy. TDF, FTC, dolu, and DTGT, FTC, and TAF. Dolu was more efficacious virologically at the time of the delivery compared with DTG, FTC, and EFV, associated significantly fewer adverse pregnancy outcomes and fewer neonatal deaths than tenofovir, FTC, or with efavirenz. And so we now have a new regimen for pregnant women around the conception time. This is the replication cycle of the HIV, and I would like to point out these new drugs that are subsidiary in their administration in a non-acting fashion. One of them, Cabotegravir, another revolution in ART, the first regime for delayed release. Studies, Atlas and Flare, and the use of rilpivirine every 2 months intramuscularly. These two studies have shown beyond any doubt that the efficacy of intramuscular shots once a month is the same as triple oral therapy. These are two very large studies with only 6 failures in type A1 and the impact of 741. But I think that it's a revolution also derived from the results of the Atlas 2M, Cabo plus Rilpi every 2 months, not every 1 month as before, is non-inferior to once a month. So it's every 2 months for 6 months in the year. These non-actives produce less stigma for the patient because sometimes we don't consider how stigmatic it may be to have a drug daily. And if you have a confidentiality issue as a patient, this is an advantage. Just 6 times a year, and this also improves adherence to the treatment and potential DOT. It's not covered, it doesn't give you any coverage for hepatitis B, it requires a cold change. We need to use an oral lead guaranteeing safety, but also give the patients an oral regime in case they cannot come back to the new administration. It cannot be self-administered, and that may have a long-term impact on adherence and also on our ability to help these patients in our institutions. The ISR long-term tolerability, it has a long tail. It's difficulty with withdrawal of the drug in the event of toxicity. Simple injection during clinical trials has not been a problem, but after many years of injections, there may be an issue of tolerability. No problems with pregnancy, but the woman has to know that for a year or so, or maybe longer, they should not get pregnant. And then to wrap up, the IIs and how they can revolutionize the PrEP, this prophylaxis. One of the most important trials this year shows these results, which were presented in the virtual Congress this 2020, comparing cabotegravir intramuscularly every 2 months as superior to the administration oral of TDF, fumarate, and FTC. Highly relevant information. So in summary, the present and future of ISTIs are the regimes recommended in all international guidelines. Currently, we have flexibility as to the number of nucleosides we need to include in this kind of a regime. It may be only one, as dolutegravir 3-TC. It requires more study to understand the long-term impact of weight changes and metabolic consequences of IIs. The good news, however, is that neural tube defects are only around conception, and they are decreasing. TAF FTC dolutegravir is a new option for pregnant women. The first long-acting regime is based on ISTIs, and we have exciting data about Cabotegravir long-acting for PrEP. Thank you very much for your attention.
Thank you, José, for your brilliant presentation. You have driven us to think about the present and future of integrase inhibitors. Before introducing the next speaker, I would like to tell you that after the third presentation, there will be a roundtable discussion which I will be facilitating. So don't leave after the third lecture because we will have a Q&A session live. I'm pleased to introduce the second speaker, Dr. Jonathan Shapiro. Jonathan is an old friend of mine. He works at the National Hemophilia Center at the Sheba Medical Center in Ramat Gan, Israel. He is one of the leading experts in resistance at Stanford. He has been to Argentina several times to participate in meetings and symposiums, and he is an authority in the area of antiretroviral resistance. This time we have asked him to tackle a new subject, primary and secondary resistance among patients receiving long-acting integrase inhibitors. As you all know, we are in the era of Cabotegravir, both for PrEP and for treatment. And we would like to know about the strengths of these agents and also about the possible resistance issues. Without further ado, Jonathan, the floor is yours.
Good morning, everyone. It's my pleasure to be speaking to you today. I want to say a special thank you to Professor Pedro Cahn for making all this possible, and to my colleague Charles Boucher, who started organizing these meetings. My charge today will be to speak to you about primary and secondary resistance among patients receiving long-acting integrase inhibitors. They're my financial disclosures. So when we talk about integrase resistance, we always show the integrase enzyme. You can see here an inhibitor blocking the active site, and I'm going to rotate this to face us, and you can see how snugly it fits in the active site and blocks its action. The problem is when we do this, the enzyme selects for mutations. In fact, not only key mutations, but many different mutations in the enzyme that impact the inhibitor, and it no longer works. So we have 4 integrase inhibitors. 2 of these are second generation and 2 are first generation, and the difference in generations relates to resistance, not to pharmacological properties or potency, but the first and second generation relate to how they behave from a resistance virological point of view. And if you look at the molecules, you can see they look differently. Raltegravir and elvitegravir are larger and bulkier, where their second generation, dolutegravir and bictegravir, are more streamlined. And let's take an example of a first and second generation, and let's superimpose their structures one on the other, and you can see the raltegravir in white sort of sticks out. It's bulkier. And if we look at them now in the active site, here's raltegravir sitting in the active site, and look here. You see that arm? It's flopping out of the active site, which helps the virus select for resistance. And what we did when we designed the second generation, we make them more streamlined, similar to what happened in protease inhibitors. And look what happens to the structure of dolutegravir, much more streamlined, fitting very snugly in the active site, making it very difficult for the virus to be resistant. And this actually has results. you can look here at how much resistance individual mutations give to the different integrase inhibitors. You can see that for raltegravir and elvitegravir, there's a great deal of resistance even to single mutations, whereas for a second generation, much, much less. Another effect this has is how sticky they are, how well they stick in the active site, and how quickly they dissociate. And you can see that raltegravir and elvitegravir dissociate quickly, but dolutegravir is much stickier and stays in the active site and dissociates very slowly. So our first generation, single mutations have a large impact on resistance and dissociation is rapid. Our second generation, there's a small impact of single mutations and dissociation is slow, and therefore their second generations have a high barrier to resistance. And we actually have a fifth integrase inhibitor, which will be improved very, very soon, Cabotegravir, and it too is a second generation integrase inhibitor. And if you look at the structures here, you can see once again, Cabotegravir has that same streamlined structure, very similar to Cabotegravir and dolutegravir. And you can see the difference from the first generation, and all three of these molecules are second generation integrase inhibitors with the high barrier to resistance. So what difference was there when we went to second generation integrase inhibitors? What did we see clinically? Well, as you remember for dolutegravir, we had a very extensive drug development program, very large studies comparing it to efavirenz or raltegravir or darunavir or ritonavir, all given with 2 NRTIs. And over 1,000 patients in the dolutegravir arms, none of them had resistance to dolutegravir when they failed. And similarly, bictegravir, large registrational studies. Here it was being compared to dolutegravir. So actually in these two studies, all 1,200 patients got a second generation integrase inhibitor with 2 NRTIs, and guess what? 0 patients selecting for resistance. So what about Cabotegravir? Cabotegravir, from the original study looking at it, you can see in the forefront in blue and green, there's dolutegravir and Cabotegravir. In the back, the first generation, you can see very well that it has the characteristics of a second generation, but perhaps not quite as low as dolutegravir. And this is a beautiful study where they actually looked at the 5 integrase inhibitors, and they looked at the degree of resistance, what fold change you got to different combinations of mutations. Very elegant study where they repeated the experiments multiple times. And this is the figure that we were looking before. You can see that for the first generation, you get much more resistance when you look at individual mutations. And for second generation, better. Again, here also maybe a hint that Cabotegravir is not quite as good. Although here, and these are double mutants, it looks actually just as good as dolutegravir, Cabotegravir. Now, when we stress them with really difficult viruses, these are viruses now that have 3 mutations, you can see the first generation, huge fold changes. And for the second generation, perhaps on some of these, Cabotegravir, not as good. And these are already our terrible mutants, multiple mutations. And you can see that first generation, all of them, and even some of the second generation, but you can certainly see the difference. And again, perhaps a little edge for dolutegravir and bictegravir over Cabotegravir. So now we have clinical trial data, and the drug is given as an injection together with rilpivirine, a 2-drug combination. You get injections, 1 of Cabotegravir and 1 of rilpivirine, and originally it was done once a month. And the studies were very straightforward. Here they took patients who were virologically suppressed. This could be with an NRTI, boosted PI, integrase inhibitor, and they simply said you can continue your daily regimen that you're well suppressed, or switch to shots of Cabotegravir and rilpivirine once a month. This was called the ATLAS study. Probably you are very familiar. And it did very well. It was non-inferior. Giving the shots once a month was just as good as continuing your oral therapy. Very few failures. In fact, confirmed virological failures were only about 1%. Now, if we look at those who failed, again, 3 patients, there was something a little bit unique. One, if we look at the subtype, there were 2 subtypes A and 1 AG. you can see here A1. We have different types of subtype A depending where they're from. This was called A1, now it's actually called A6. It's the Russian subtype A. But actually of the failures, two of them were subtype A, 1AG, and two of them had the L74I polymorphism at baseline. And this is a change from L to I that we sometimes see as a polymorphism in naive patients. And actually here, 2 out of the 3 had it at baseline and in failure, and one of them actually added a 155H mutation. The second study called FLAIR, here actually patients were naive. They first received dolutegravir, abacavir, 3-TC in order to become undetectable. And then they could either simply continue their 3-drug dolutegravir regimen or switch to the once-monthly injections of cabotegravir and rilpivirine. And once again, fantastic results. Non-inferior with shots, and it didn't matter which regimen you'd come off of. Again, excellent results. And again, a very small percent, about 1% of patients fail. And here they are. And interesting enough, let's look again in this study as well. All of them were subtype A from Russia, and all of them had the L74I at baseline and maintained it at failure. And here actually all 3 added integrase mutations. Again, only 3 patients, but again, this characteristic. And we look at the 2 studies, you can see that almost all the patients had both the subtype A and L74I as a polymorphism at baseline and upon failure. So I think we can conclude that very few confirmed virological failures in both studies, around 1%. But in those few, both subtype A and baseline L74I were often seen. And then the third study was performed to see if we actually have to give it every month. Maybe we can get every 2 months. So either patients from the previous Atlas study or else new patients were now enrolled, and they simply could get the shot once a month or a higher dose once every 2 months. And here too, it was found that actually giving the shots once every 2 months was non-inferior to giving the shots every month. We haven't seen detailed data, but from the presentation we saw, guess what? Once again, L74I polymorphisms and many subtype A's. So what do we know from these 3 studies? So first of all, IM cabotegravir rilpivirine was non-inferior to oral therapy. In addition, giving the shot once every 2 months was non-inferior to giving it once every month, and success rates were very high. Confirmed virological failures, very rare. Now, some of those few failures actually did fail with integrase mutations, and the combination of subtype A along with baseline integrase polymorphism L74I was often seen in confirmed virological failures. So what do we know about this L74I? Well, we do know that it's located actually close to the active site, and a sister mutation, L74M. So if you have an M instead of an I, we know that actually is an accessory mutation found in patients who fail and can add to resistance. Additionally, we know that in some subtypes, L74I can be found. Now here, the Stanford database can really help us, because in the Stanford database, and Bob Schaefer, of course, he is the founder and the PI, you can look and see which polymorphisms you have at every position of the integrase in all the different subtypes. So let's take a look. This tells you which amino acid you have, and we're looking for I, that is the light blue. And here's subtype A, and at the bottom, those are all the different positions, and we want to know 74. Here it is, and we want to know how many are I, that's in blue. So actually about 20%. So of subtype A's, 20% naturally are L74I and not L74 as we see in others. So is that the same in all subtypes? Well, let's look at subtype B. That's by far the most common in the United States and in much of Europe. And let's look for that little blue line. It's really low. So as opposed to subtype A, which has about 20%, almost none of the subtype B have that L74I. And we'll just look at one more subtype that's an A. This is AG. And again, it's pretty high. So you can go and look at all of them, and some of them have L74I and some don't. Now this, if you remember, these were actually subtype A's from Russia. They're actually known as A6, not A1. And folks from Moscow took a look and found that actually in their subtype A, almost all of them, 97.9% have L74I. So although around the world it's about 20%, and those in Russia, almost all of them have L74I. So what about in the laboratory? Have we ever found it associated with integrase L74I? Well, there was a great study done where they looked at selecting for resistance in the different integrase inhibitors. That was done by Bluma Brenner and her group in Montreal. This was formerly the group that worked with Mark Weinberg. And they challenged them with the different integrase inhibitors, and actually one of those did select for L74I. You can see, together with some pretty serious integrase mutations, L74I was selected as well. Again, only one experiment, but it was seen. And actually, in dolutegravir, we've also rarely seen L74I. In the Viking studies, we know today that you got to use dolutegravir twice daily in salvage. But in the early Viking studies, some still used the inappropriately low dose of 50. Now, in these patients, we clearly saw you should use twice a day, but there were data on those who used once a day against resistant virus. And in 2 of these, actually, when they failed, there was a mixture of L74Ms with I in the failures. Again, not a lot, but a hint here that 74I could be relevant. And finally, in one of those monotherapy studies that we know now not to do, a study here from France where patients were switched to monotherapy, one of them actually failed with an L74I together with E92Q. And they went back and did proviral sequencing when the patient was suppressed, and they found there was actually a baseline L74I mutation there. So not a lot, but a hint here that we have seen L74I with integrase resistance. Now, this question about subtypes and polymorphisms, do we know if it can ever really have an effect on resistance? So we know that subtypes have different patterns of polymorphisms throughout the genome. That's why they're different subtypes, because they have this genetic difference. And a subtype that's rare in one can actually be common in another. Now, polymorphisms can contribute to resistance, but usually only together with other mutations. And sort of, you know, we use different words, but usually if it's a big impact on resistance, we call it a mutation. If it's a small impact, we might call it a polymorphism. Maybe in the middle, it's an accessory mutation. But we know that some polymorphisms have no impact on resistance. But we do have a number of examples already with other drug classes that subtypes have impacted resistance. Here's a paper from our group in Israel, a large collaboration of many good colleagues here in Israel, together with Virologic. And we were treating patients with the protease inhibitor nelfinavir. Some of them were Israelis who came from Europe or America with subtype B, and some had come from Ethiopia with subtype C, and they were being treated exactly the same in different clinics. And we found that those who had subtype B usually failed with the D30N mutation, but those with subtype C usually failed with L90M. And everything else was the same in the clinic and the patients. And then when we looked, subtype C commonly has the polymorphism M36I, N93L, and together apparently these were pushing to their L90M and not the D30N. And there were other polymorphisms seen, and also other folks from other subtypes. Some were seeing this, some weren't, but clearly there was an impact on nelfinavir resistance. And actually years later, a wonderful study done by Annemarie van Dam and the late Riccardo Camacci, they actually were looking at nelfinavir and looking how these polymorphisms impacted resistance. They actually found that different polymorphisms were affecting the genetic barrier. And it's an elegant study, and you can see here, this was the impact on the genetic barrier. If you went to the left, then you were actually reducing the genetic barrier, making it easier to fail. And if you went to the right, you were heightening it. And take a look at here. 36I, it actually does dent the genetic barrier, but we saw some others like the 20R also. Then we went back and we looked, subtype C also commonly had 20R. So maybe it wasn't just the 36, maybe it needed other changes. And of course, Hemophilia is a drug with a low genetic barrier, and it was having this impact. So polymorphisms present in subtype C and other subtypes can impact susceptibility to different protease inhibitors. It may be that a combination of protease inhibitors need to be present, but we're not sure. We don't know if it's one or multiple. Now, we also looked at this in other drugs, specifically Kaletra. And there, although we saw these polymorphisms, it had no clinical impact, nor have folks found any clinical impact on darunavir when it's boosted. And my hunch is the change it does in genetic barrier is not high enough to impact these very high genetic barrier drugs. The high genetic barrier of Kaletra, of lopinavir, and of darunavir is so high that these small changes of the subtype do not have an impact. That's my theory. So is this true only for protease inhibitors? Actually, we have other examples where differences between subtypes in clinical resistance have also been seen for NRTI, and even entry inhibitors. I won't be able to go into detail, but some examples are, for example, the rate of selection of K65R is different in subtype B and C, and you actually select more rapidly in C because of actually codon differences at position 64 and 65. Again, the late Mark Wainberg had a big part in showing that. The pathway to resistance of efavirenz in subtype B and C, you see more K103N in subtype B and 106 in subtype C. And even a drug that's not yet approved, fostemsavir, but probably will very soon because in the United States it's already been approved. This is a drug where if you have subtype AE, you have polymorphisms which reduce actually susceptibility to it. So actually we do have examples, although in this case it's usually drugs that do not have an exceptionally high genetic barrier, but impact of subtype on resistance has rarely been seen. So polymorphism L74I, subtype A, failure with cabotegravir. What do we know? Well, we know that there's still much to learn, but a few things we've observed. First of all, the vast majority of patients who receive IM cabotegravir did not experience conferred biological failure. Actually, over 98% don't. And this, of course, is because the high barrier to resistance of cabotegravir. Among those failing, a surprisingly high percent did harbor at baseline the L74I and were commonly subtype A. This could be a chance event, but it was encountered in all three studies. Now, perhaps, and this is a theory, that if you had other risk factors and you already had things which were damaging your success, the addition of the L74I and subtype A would contribute to your failure. Therefore, we saw it so rarely, but pretty consistently with 74I and subtype A. Now, if so, it's not clear if 74I alone is enough, or if there's additional polymorphisms, perhaps in subtype A, which also contribute. That we don't know yet. So this could maybe be relevant only for subtype A, or maybe for additional subtypes as well. And what's clear, we certainly need additional research because further study is needed for this, I think, interesting phenomenon of this drug, which we will soon hopefully be using in our clinic. And with that, I'll acknowledge my great team that I work with, my friends and colleagues at National Hemophilia Center in Israel, who are a pleasure to work with and take care of all our patients. The patients and investigators from the studies I showed, and permission to use these slides. And as always, if anyone's listening, Donald Trump's a great guy. Remember that I said so. So thank you very much, and I look forward later to our having a discussion. Thank you.
Muchas gracias, Jonathan, por esta maravillosa presentación. Resulta muy interesante conocer todos estos aspectos específicos relacionados con los distintos tipos de tratamiento. Now, I would like to introduce another good friend of ours, Dr. Alexandra Compagnucci. She is Argentinian. She graduated from Buenos Aires University, and she has been working for several years at Inserm in France. She is one of the principal investigators of the PENTA trial on antiretroviral treatments for the pediatric population. I believe there are few people who are more qualified than she is to talk about integrase inhibitors for the pediatric population. You know, children are always lagging behind when it comes to treatments. It takes longer to address treatments to them, and although in the northern hemisphere the pediatric issue is not as important, in the southern hemisphere, especially in Africa, there are still many cases of pediatric AIDS. After her presentation, there will be a Q&A session. But now, Alexandra, the floor is yours so that you can talk about integrase inhibitors for the pediatric population.
Hello, good morning. I thank the organizers again for their invitation to be present here with you today. I'm very happy to be here at such special times of the pandemic. I will talk about the role of pediatric and RTIs. And the most important thing before talking of children treatments, we need to remember the context. We have to know that 1.8 million children live with HIV today. 95,000 children younger than 15 have died from AIDS, and that children have lower viral replication rates than adults, among other things, because there's fewer optimal formulations for them. Despite our progress in getting drugs for children, the gap still persists in treatment, in access to treatment. We all know that children have to start the treatment as soon as they are diagnosed because they start all too early, and these treatments are associated to adverse effects. And if the formulation is no good, this has an impact on adherence, which in turn leads to a resistance and to an adverse effect on response. And if we have high viral loads with high replication, there is the risk of increasing the problem. What we need to bear in mind when we start treating children is that we need viral suppression, fast and durable, with drugs that have a toxicity in the short and long term, but in particular with formulations adapted to children. Syrups are no longer a solution for children. They have to be good and acceptable for them. The frequency of administration, potentially, if it's possible, once a day, and the limit of availability of fixed combinations, in particular in small children. Another important thing is drug-drug interactions. The NRTI class is very promising in regimes for children. Here is a diagram of the formulations available, single formulations or combined formulations. And this is the part that is in particular that is not all too available. Let's start with the NRTIs. We know Cabotegravir. We have a long-standing experience. The Impact P1066 has given a lot of data. It can be used since birth. That's important. The formulation is that it's coated tablets or chewable or granules. It does not need a boost. It's well tolerated in the short and long term. But there's a problem that twice a day and the low genetic barrier plus the difficulty to administer it to very little children is a problem. Clinical example, an adolescent girl. It comes from the case comes from Spain. She is pregnant. She has a very high viral load. She is 38 weeks into the pregnancy. So we give them what you see there at the top, Cabotegravir, to decrease the transmission, and in very few days the viral load flattens. And in the case of this child, the newborn, had undetectable viral load and has not been contaminated with the usual treatments. Tolerance was very good in this patient in particular. With raltegravir, we have long-term experience. 240 weeks into this protocol 1066, we see important data as to safety, and in particular in the real little children who have received granules and chewable tablets, the virological response is more significant. But those with adult tablets, viral response in the long term is no longer so good. So this might affect adversely the viral response in to other integrases. We also were lucky enough to have access to dolutegravir, which is an inhibitor without boost. It has a rapid, durable viral response. We have experience in adults as to high genetic barrier. It's related with low toxicity. It can be given once a day only with few drug-drug interactions. It's available for children in tablets of 50, 25, and 10 milligrams, but not everywhere. In Europe has been approved after 6 years of age, and it can also be used as fixed in adolescents. Fixed combinations. Penta, our group, studied the role of the dolutegravir in children who require treatment from day 28 of birth until 18 years old. We're talking of pediatric populations here. First line and second or first failure compared the two arms with the standard treatment with a viral assessment criterion, which is safety, of course, and we've done lots of pharmacokinetics during the study, the trial. These are the existing doses. A patient in this weight requires 35 milligrams, so one tablet 25 plus one tablet 10. Very complicated for the families, and not all of these formulations are available in all countries, in every country. In Penta, we have done several pharmacokinetic studies by weight and by formulation, solid and dispersible tablets, to see whether it was possible for children of more than 20 kilos could receive the adult dose. This pharmacokinetic study has been presented in other meetings. It's just been published, and the 50 milligram tablets can be used in children with more than 20 kilos of weight, which facilitates administration, plus also we may treat the family with the same tablets. It's very useful in low-income countries. And the possibility of dispersible tablets as well if the patient cannot swallow the tablets. The PRINCIPS study on efficacy and safety are underway. They're being analyzed. The outcomes are being analyzed. So if we meet next year, maybe I'll give you the results. More good news of this study associated to the impact as well, DOLU for small children. The use of dispersible tablets approved by the FDA and therefore the WHO has welcomed this effort. It's an excellent piece of news. We all know Cabotegravir, one of the new integrases that exist in fixed formulation of 50 to 125 TAF, authorized for adults in 2018 and last year for children and adolescents weighing 25 kilos or more. Recently, we've seen data on children after 2 years and 14 kilos. Again, this is the size of the tablet compared with the other one. And now we'll focus on this weight range. These are controlled children who have good renal function and CD4 is above 200. And we have given them the fixed formulation, low dose of Cabotegravir, a TAF 3TC, and as you see here, exposure with Cabotegravir or on Cabotegravir is comparable in small children, adolescents, and adults, and you'll see that exposures are similar. In connection with efficacy, it's been excellent. 100% of patients have preserved their undetectable viral load and a very high adherence rate. Here, you see the acceptability study we performed. We gave the patients. It's difficult to understand. In green here is easy or super easy to swallow. This is the perception of the size of the tablet, acceptable in general, and perception of the taste. There was either no taste or they thought it was acceptable. The idea is children don't perceive the taste. So acceptability, of course, in children is essential. What else do we need to consider when we use NRTIs, drug-drug interactions, of course, and we know NRTIs have few interactions. The ones listed here are the ones that we're more interested in, association with TB treatment or with food intake and the contraception, in particular among adolescents. For example, when we give raltegravir and rifampicin, there may be a decrease of RAL levels. With Dolu, we know we have to double the dose. There was also a pharmacokinetic study that was done to assess patients with TB and what kind of concentrations they require. Cabotegravir, you see the concentrations, so no. And as to contraception, it's interesting to see this among the adolescent population because of the potential interactions. These are the references, and you can find this information in the Liverpool site, which is a drug-drug interaction database that is usually used. Contraception pregnancy is another topic. We've talked a lot about the role of NRTIs and the potential of neural tube defects, which sort of has been clarified. But we must create awareness among adolescents as to the need for contraception. If we explain the girls know how to get protection in order to take their medication without any problem. The guidelines and the UA and the recommendations, NRTI still have an essential role. From birth, the use of Ralti and Dolu and Bicte are now being considered first choice. In younger children, we need to have this part here a little bit more covered. The same for the PENTA guidelines. Here it's in red because we are going to get the authorizations quickly, promptly for smaller children. And these are going to be the alternatives of choice for the third agent when treatment is set on for the different age groups. What do we need to think of when we talk of integrases? Is it only triple therapy options, or are there other options? And also another important thing is the fixed formulation and the priority list of the WHO for universal treatment. NRTIs may be associated to others like Dolu and Darunavir, the use of 3TC with Dolu, and also the possibility of association with non-nucleosides like rilpivirine, but we don't have info for children. When we talk of dual therapy, we base ourselves on this study, Dualis, two drugs versus switch. There is no inferiority here of the double versus the triple. And Penta also has a study for children comparing switch and double therapy in children who are controlled. When they did the switch with dolutegravir to darunavir, it's still underway. We hope to be able to give outcomes in the next meeting. This is a potential association if we eventually need a third line. When I was talking about the WHO priority list for universal treatment to optimize pediatric treatments, there's this list to have rapid access to pediatric formulations. And look here, the tablets, for example, association of 3TC and abacavir, or the association of TAF and FTC with DTG. So all of these in view of potential universal treatment for children. This is part of this global accelerator in order to accelerate formulation availability in pediatrics. So conclusions from all of the above, we can say that NRTIs have a privileged place in strategies to treat children. As research keeps progressing, and thanks to the obligation of pharmaceuticals to initially start with a molecule developed also for children, not only adults, we are getting more and more information. These inhibitors also must be thought to build new strategies with fewer drugs, and also the association with other drugs to do third-line treatments. We all need to incent as much as possible the development of all these formulations, which will allow patients to be aligned with adult treatments, and in particular in countries of low and middle income. And now, in wrapping up, I'd like to thank you, obviously, as members of the Fundación, all of the colleagues and friends from Argentina for their trust and friendship and for this invitation. Also the children and their families, because being involved in a clinical trial is a challenge. It's not easy. You all know this. And also all of the sites which work day after day in order to provide quality data, and the CTUs with whom we work on a par to obtain excellent data. And this is the French fall image at a time of the pandemic. Thank you very much. The use of more spaced schemes, Cabotegravir, rilpivirine in higher doses, it's more comfortable for patients, improving compliance. Does the higher dose create more adverse effects? according to the data that we have nowadays, Cabo and Rilpi are a very well tolerated regimen, despite the low dose initially. There are only local reactions as AEs, but it's not regimes that would produce problems. The AE profile is very good. They are long-acting, so no problem. Hello, José. Good morning. Good morning also for Alejandra. I had my internet was down and I could not open the session. I would like to thank you both and Dr. Shapiro for your brilliant presentations. One first clarification, Dr. Shapiro, because of the religious festivity, is not going to be present in the debate. Very well then. A generic question for Jose. Thinking not of us who are testing new strategies and new drugs, but for those who work in remote places, in a hospital, in an office, at distant places, there are very good options with over 90% efficacy in many cases. What would be for them the criteria to select this or that integrase inhibitor or onset of treatment, thinking of all those very positive options? For us, in general, in Spain, our local guidelines recommend getting started with an INI. And in general, the discussion starts with why not an INI? Within INIs, obviously, there are some that are, there's only one that is for single tablet, and dolutegravir that allows you the flexibility of 2, and then going down. And the way in which it's being used in Spain is induction maintenance. And then afterwards, when it's undetectable, go down to only 2 drugs. And then raltegravir that has, is better as to interactions, and it relates better to weight gain. Obviously, if the patient has hepatitis B, they will need a regime that including tenofovir or fumarate. And if it's a pregnant woman, in general, clinicians tend to use raltegravir more. Perhaps the factors, for example, with TAF are better. With bictegravir, we don't know much about pregnancy data. At the CROI, these were the major determinants. And of course, we all are involved in public health systems. And so the combination of dolutegravir and 3TC is advantageous because of cost. In Spain, infections from B virus in new patients is 4%, 2%, very low. So it's not really a limiting factor. Nor with INIs. And if we set aside INIs, we still have protease inhibitors and the question of compliance. And I think integrase, second generation integrase inhibitors, darunavir would be the drug of choice. And this will allow us to be used in double therapies. And now a new drug that is still not for single tablet, but as I said in my presentation, also we are seeing problems with weight gain with INIs, and second generation will see some switch to another drug. Alejandra, for pediatrics, what would be the standard of care if you had to indicate a Latin American pediatrician with limited access to new formulations? What would be the best strategy for Latin America? pediatricians. I have a little bit of echo in my soundtrack. The echo is because you are opened as an audience. Your session has been opened as that. Now, again, I'll repeat, suggestion to start children, naive children who've never had treatment. Among the available options in the market, what would you suggest? Perfect. Okay, let me close that other session. I heard you clearly, Pedro. If I had to make a recommendation, we were commenting before. I showed you what the recommendations are for the American recommendations and those that we use at Penta, which have, in particular, can you hear me? Yes, yes, we can hear you. One of the things precisely that we are looking into, and we will have results soon in Penta, is using dolutegravir first line for small children with the view that these tablets, or because they are easily available for pediatric population, and also they give us the possibility of alignment with preferential adult regimes as recommended by WHO. So we will have the results pretty soon. And if we had to consider first-line regimens for dolutegravir, in particular for little children, has a prevailing is a prevailing option. For adolescents, we have other fixed formulations as well with INIs like dolutegravir and other formulations with bictegravir. And this has to do too with having access in the market and for these populations. I commented about dolutegravir because for real small children, we already we have the availability of dispersible tablets as well. Another question, what's the criterion, Dr. Arribas, to select in a situation of switch dolutegravir, 3TC, or rilpivirine? You are muted, José. I always insist that before the switch, you have to know whether the surface antigen is positive or not. But in general, I prefer dolutegravir 3TC. There's nothing in dolu-rilpi that would be superior, with the exception perhaps of patients who have M184 W file. So dolu plus 3TC has the calorie requirement vis-a-vis rilpivirine, doesn't have interactions with omeprazole, which is also relevant for many patients. Not only because you don't have to prescribe omeprazole, but there may be other medical reasons and interactions, and you can use it. With dolu-rilpivirine, it is a possibility of a bridge regime until you can switch to cabotegravir, and the patient the rationale is a little bit weak in general, but I prefer dolutegravir 3TC, which is also cheaper as well. So that's something. If I am a fan of any drug at all, it's 3TC. We have remarkable evidence, and so in general, I prefer dolu and 3TC. So you're a fan of 3TC as much as you are of the Real Madrid soccer team. Yes. At Penta, we're always now envisioning a protocol associating 3TC and dolutegravir. So the strategies for making it lighter have been foreseen for my patients as well. And another comment, because perhaps this association of dolutegravir and darunavir seems weird in one of our trials, but the idea was checking whether saving nucleosides in children has an impact, using it as a strategy. There are, I'm talking to a pioneer in simplifying with single therapy, but this weirdness comes from there, trying to simplify. So we are looking into this strategy, as I was saying, double treatment associated to darunavir to see whether nucleoside saving has an impact on toxicity. We're looking into it right now. We'll see the results in due time, and this will also allow us to obtain data for third line as well. Doludaruna, Jose, in your practice at the La Paz Hospital, any patients with those two drugs? Relatively few patients, I would say. It's patients who come from major transcriptase mutations, problems with nucleosides, and so they end up with this combination. Fortunately enough, out of our 4,000 patients, I would say less than 10 with this combination. It's a very powerful combination. It is a sort of simplification for patients who were on complicated regimes, salvage regimes, that is. Talking of complicated patients, Alejandra, in your area, the most complicated patients are surely adolescents and long-term survivals who had vertical transmission originally, exposed to different problems, compliance not the least, and nowadays we see them 18 years of age, 20, and we see those completely red genotypes, multiple resistances. What do you do? What's your approach in those cases for adolescents? Yes, in general, we have patients who are mostly controlled, but we talk about this with our pediatric population. I know the clinical trials and I know with these patients even from pregnancy, and we use genotypes and the case history, the history, trying to use fixed formulations mostly currently with Cabotegravir, for example. And the Spaniards have quite a bit of experience with these formulations, INIs. And another interesting topic is the trials that have already started with formulations with Cabotegravir and long-acting drugs that may favor compliance in these patients, because what we need is maximum compliance in adolescents. Jose, in your experience in Madrid, whatever the literature says, weight gain with INIs, is it a minor problem, intermediate, huge? Bearing in mind that in your population you don't see many Afro women who are obese. Yes, not definitely. We are not like South Africa. We have very few Afro women in my unit. Probably 20% are women, and our immigration is not essentially African. Occasionally, we may see some. The combination that has increased the weight the most in advance has not been much used in Spain because of cost concerns. And so
we may occasionally see a patient and a weight problem, but it's not really a first-rank problem for us. This is not at all. It's not what South Africans complain about. Thank you, Jose. Alejandra, what about weight gain in pediatric populations? Basically speaking, is the same as what Jose is saying, but what we are going to see now in our clinical trials, where we will be able to compare definitely versus the standard treatment, comparing dolutegravir, for example, and there we'll see whether there are differences vis-a-vis weight. The best way to check on these data is in particular with clinical trials. This will be a great opportunity to see whether dolutegravir has an impact or not. In the general population, well, children are there too. They eat differently, of course, and the access to TAF for little children, you all know, it's basically the same situation. But clinical trials are the ones that will tell us, will show an answer on the impact of weight gain, in particular for dolutegravir. I think we've had really, I don't know if it's been very, I don't know how useful it's been for the audience who's listening us, but I always learn a lot from meetings with people like you. So I'd like to tell you that we have more sessions today in our seminar. I'm trying to fast forward my slides to show you. Just bear with me for a second. Let me see if we can see the slides. Because I'd like to tell you, no, I can't. I can't make it move. Anyway, we have more sessions today. The coming sessions will have the possibility of listening to outstanding panel members. The next session will take place shortly, a couple of hours. You have a program there with you. I cannot show it to you. My computer refuses to go forward. Can you see the screen now? Yes. All right. Session 2 will start at 2 p.m. Argentine time, and we'll have Francois Venter from South Africa, and Rebecca Sash from the US, and Claire O'King from London. The session will be coordinated by Dr. Omar Suede, and we will discuss weight gain during session 2. The implications of using INIs during pregnancy, and Dr. Orkin will talk about double therapy and the progress there. At 6 p.m. Argentine time, 3 more speakers on PrEP, and Rafael Lanovic, who's the main investigator of 083, talking about advantages of dolutegravir or alternatives, and Dr. Suede, who will talk about the use of PrEP in Latin America. Marley Branson from the US will talk about PrEP during COVID times. If you wish to have a certificate of attendance for your resumes and your hospitals, you will get the certificate once you complete the survey that you will be getting once our meeting is over. And you will only get the certificate if you have completed it. As to the complete materials of the webinar will be posted in our website, as well as at the Fundación Huésped website. If
you want to contact virology education, you can do it via different social networks in order to follow many of the activities that we have entertained here. Our special gratefulness to GSK, who have sponsored this symposium, but they have not been involved in topic selection or speaker selection, which has been the responsibility of virology education and us. So we thank you very much for your participation, and we will meet again at 2 p.m. and at 6 p.m. and as of tomorrow, 8:30, with a formal beginning of the Fundación Huésped symposium. This year it won't be face-to-face, unfortunately, but the time will come for us to meet again. Thank you, José. Thank you, Dr. Shapiro. Thank you, Alexandra, and all of you for being present. Special thanks to Micaela Figueroa and Jessica Nilsson, who have helped us with the technical part, plus the Argentine people, the translators, for those who don't speak English. All right, thank you to all of you.